with aligner system. And this is the topic that we will discuss. And hello, everybody. I hope that everyone can hear me properly. So thank you so much for this connection. It's my pleasure to be here tonight and sharing with you my experience with aligner on a topic that I really love and a topic that I developed in the last couple of years. So, the treatment of impacted canine with aligner system. And this is the topic that we will discuss with aligner system. And this is the topic that we will discuss, and I will share with you my experience today. So, first of all, we will try in our outline to understand how it is possible to manage and combine this big problem of ectopic canine, which is the incidence, which is the etiology, and the prognosis of this problem. So let's try, first of all, to focus on our problem, how to diagnose, and which is the ideal sequence of treatment when we are talking about impacted canine. Then we will talk about the aligner approach and in particular how is possible to be more effective and more to give more reliability to our treatment plan, how is possible to combine aligner with TADS, so with temporary anchorage device. But even I know that is not so fundamental, but let me again introduce myself for the people who don't know me. So my name is Alessandro Mario Greco. I live and work in Rome, one of the most beautiful city of the world. And my office, which is not so far from the center of the city, just 1 kilometer from the center of the city, is a full digital orthodontic office and is based pretty 100% on aligner treatment. So we can say that nowadays, pretty all the phase 2 that I'm treating are approached with an aligner system. And this is why, because I really believe that this is the present and the future of orthodontics. Of course, in my past and in my present and future, I am a member of uh, most all the important orthodontic society in the world. So I'm member of the Italian board and European Board of Orthodontists and member of Italian Society, European Society, and all other societies. Something that brought me to travel worldwide in the last years. Of course, not the last one, but in the last years. And I was really shocked, actually, when I start reading the editorial that was published on the Journal of Clinical Orthodontics in 2018 by my friend Bob Kime, the editor of the JCO. And he stated that, of course, in this moment, at this point, with all the new introduction, the new features that have been introduced into the aligner system, is now uh, possible to think that there are no type of case that cannot be considered treating with clear aligners. And we are exactly there in this moment. We are exactly there with this specific approach. And in particular, I believe that for my personal approach, if I want to treat even super complex cases like extraction, impacted canines, and we will see this, the only thing that I always need to do is combine all my knowledge in terms of biomechanics, all my knowledge in terms of and respect of biology of the individuals, and simply trying to move all my background, all the things that I learned in my orthodontic education, in my orthodontic formation, and I need just to put all of these things inside the digital system. Because what is really fundamental for me is not the use of the plastic, which is an amazing component in what I'm doing, but more than this, it's the plan that we can do and we can set in our digital orthodontic approach. So simply by moving teeth and creating the ideal setup. This is the way, and this is the way to change our mind from an conventional orthodontic approach to a digital orthodontic approach. And we know that nowadays we have a lot of new tools in our everyday life, in everyday practice. And all these tools are amazing when we want to have a more precise diagnosis, a more precise treatment plan, when we want to set up everything from the beginning and we can look and observe the results, but even more precisely, we can analyze the movement step by step. And in particular, nowadays, we can treat with aligners patients with a customized appliance. Because if you think about aligners, aligners are the first customized appliance introduced into the orthodontic panorama. And this is amazing because we can now treating with a digital approach means all of this. We don't need to start with the end in mind because we have the end in front of our eyes, in front of the screen of the computer. But without a mind behind all these beautiful tools, the mind of the orthodontist, everything is useless. So we can't simply create a proper digital plan if there is no mind that is guiding all the process, if there is no director that is simply guiding all the movements and the staging and the approaching the proper biomechanics. And of course, in order to achieve a proper outcome and success in our orthodontic treatment, we need to combine two fundamental concepts. One is the evidence-based approach that should always lead what we are doing, and the other one is the approach based on patient-centered care, what we can call patient-centered care. So we need to always think about patient experience because, of course, the quality can be assessed across three key dimensions: the clinical effectiveness of what we are doing, safety, and in particular, the patient experience. This is the reason why it's fundamental. And this is the reason why nowadays my workflow is completely different because I can start scanning every patient and creating, first of all, a digital environment and a digital records for all of my patients. Second, normally I receive a clean check with my Invisalign system and I start activating the 3D controls, as you can see in this video, and I start moving teeth by myself. So what I'm doing, actually, I set all the clean check simply by moving teeth according to my preferences. So what I'm doing, I can set the three-dimensional position of the teeth, correcting the rotation, correcting the 3D position, moving in the selection of interproximal reduction, open some spaces. I can set by myself the position, as you can see in this picture here, of the attachments, the inclination, the angulation. So all these kind of things that I normally do by myself. With the shape and position of the attachments. And at the same time, I need to respect the Bolton index, and something that I normally do in all my digital plan, setting the proper occlusal contacts. So all these kind of features are represented by my daily stuff. So every day I have some clean check and to prepare. And so some digital setup that will be done by hand, let's say, so in a manual approach, without texting, without giving information to the technician, but simply by setting all the 3D controls and setting the position of the teeth by myself. And of course, the last part of what I'm doing, it's simply, in case of complex treatment, combining some what I call anchorage modulation. Anchorage modulation is a concept in which, of course, if I need to simplify some really complex treatment, I can combine some surgical procedures like microperforation, piezo-excision, or I can simply manage the anchorage by combining TADs. And this is exactly the topic of which I will discuss today with you, because tats represent a really, nowadays is no more an innovation probably, because they represent a really paradigm shift on the scientific revolution, because we know that when we learn something and this is science, then there is an anomaly that change everything, that change something that we normally know. And what we know in orthodontics is that if we apply a force, an action, we have a reaction. With the use of TADS, we can absolutely avoid that reaction, because that reaction will be simply controlled by the use of TADS. And it means that they really represent a scientific revolution, a paradigm shift. And it's not a new topic, because we know a lot of things today. We can find a lot of literature. Personally, I contributed during the last years, in the last 20 years, in writing books and papers based on TADS. And so it's something that I know and I invested a lot, because I really believe in TADS. And what we know today about biomechanics is that we can apply, talking about TADS with aligners, but even generally, we can apply a direct force on the TADS. So in that case, we will use a direct anchorage. We can have a sort of mixed anchorage, which is partially on the teeth and partially with an indirect connection with the teeth, and partially a direct connection with the ectopic element, for example. Or we can simply prefer a concept that we can call indirect anchorage. And in that case, we are generating a sort of pseudo ankylosis, as we call, in terms of blocking any kind of movement on the canine and using as an anchorage group just to move all the other teeth in mesialization, like in this case. So we have three different approaches talking about biomechanics, and this is something that we know. But of course, not always we can apply, for example, direct anchorage. Of course, the pros is that the force will be directly applied from the TAD to the teeth. We can minimize the side effect, but of course, the distance between the TAD and the application of the force will generate a vector that sometimes could be favorable, sometimes will not. This is the reason why we sometimes need to control this kind of force with the power arm. And we need to ask ourselves, okay, this is my action. So this will be applied close to the center of resistance or far from the center of resistance. So we need to activate our brain to understand if it's possible to apply a direct anchorage. Sometimes we are obliged to move to indirect anchorage, for example. In that case, we create an anchorage unit, creating a stability of the group. And in that case, we try to simply avoid any kind of adverse effect. But of course, it means that to create the anchorage, we are not only using the TAD, we will use the teeth. And so, of course, it means that the force will be loaded on the teeth and we can have a dental solicitation. So in that case, we will use the anchorage, but at the same time, we will have the reaction, which will be in somehow uh, uh, affecting the teeth, not only the screw, not only the tat. This is the most important cons, in my opinion, in the indirect anchorage. Most commonly, let's say that we try very often to achieve a mixed condition between direct and indirect anchorage, because in this way we can manage with one TED some multiple vector of forces. So for example, in this picture, as you can see, I'm keeping stable the position of the second molars and at the same time with two segments of elastic chain, I'm retracting the first molar and retracting the premolars. So we can have multiple vectors simply by having one tab. So it means maximum anchorage fruition, and that's fantastic. But again, this is not always possible because it depends on the design of the mini implant, of the mini screw that we are using, and anytime, sometimes we need some modeling of the power arm or the connection, as we can see in this picture, that we need to model by ourselves. So we need to create a simple arm that is going a segment of wire, in this case, a round wire, which is going from the 7 is modeling up to the TAD, which is something that we cannot find already modeled, but in order to be precise, we need to generate by ourselves. So these are the things that we know today about biomechanics, but still there are no indication in the literature based on what I call the real biomechanical need. That's the reason why, by myself, I decided just to have a sort of classification of the need of TADs in the different condition. And following this concept of the real biomechanical need, we can divide the indication of TADs in RBN number one, which is a simplification of our mechanics. So this is what I call simpler. The RBN2, which is in all that situation in which TADs are really necessary to achieve a complex movement, like a case of asymmetrical mesialization of the molars, as we can see. So in that case, is not a way to simplify the mechanics, but this is a way in which we need TADs to uh, apply that specific biomechanics. And RBN number three, so real biomechanical need three, in which TADs can be considered what I call a game changer. Game changer means that in that specific condition, TADs can change our treatment plan. So in that case, it's not a way to simplify, it's not simply needed, but they can arrive to change our treatment plan. So if normally in our treatment plan, we can decide to avoid to try in impacted canine, for example, in adult patients to recover the position, with that, we can do that. So this is the reason why game changer represent one of the most interesting condition that we can approach with TADs. And most of them are, for example, when we don't have sufficient number of teeth to support the movement, when we have an impacted canine in case of difficult anchorage, for example, and more generically, when we can define an hostile movement. Hostile movement is a really complex impacted teeth position, for example. And I think that generically, all the impacted canine can be considered like RBN number three. Because with the real biomechanical need number three, we indicate specifically all that condition of impacted canine that we need TATs to completely change our treatment plan. And in case of, and we can approach to simplify and need, and in particular, creating the proper anchorage condition and the proper anchorage sources. And talking about the problem and focusing on the problem that we can treat with this approach, let me spend few words about the incidence of ectopic canine, because we know that it depends on from author to author. Actually, some authors say that the incidence is between 1 and 3%, while from Frank, for example, from another author, we have an incidence which is between 6 and 19%. We know for sure that the frequency is pretty higher on maxillary than mandible, is more common in Caucasian people than in Asiatic people. So the relationship is 5 to 1. So there is a huge difference, and is more common in female than male. So we know from literature all this particular condition of the ectopic teeth. And in only 10%, 8 to 10% of the situation, we have a bilateral impacted canine. And of course, they represent a challenge pretty often. The reason why it happens recognize two different theory in terms of etiological theory. We know that we can have, for example, from the mechanical theory, when we have a dental velar discrepancies, a really constriction of maxilla, a premature loss of the deciduous canine, the presence of neoformation of delaceration, for example, can create, or some other dental anomalies in shape or dimension can generate what is called the guidance theory of canine palatal canine displacement. On the opposite, there are some genetic origin that is calling from irradiation, fever, and all that kind of endocrine pathologies. But most commonly, the mechanical theory is absolutely followed by most order nowadays, in particular by Professor Becker from Israel, which is one of the most important eminent uh, researcher in this field. And we know that in order to prevent this problem, inspection, palpation, dental maturity analysis, x-rays that should start from 10 years, and preventive extraction of deciduous canine together with maxillary expansion can be a really nice way to prevent this kind of problem. In particular, when we have an impaction which is not really a transposition, like the one that we see in this picture, because in this case, when we have this position is a transposed canine, it's not impacted because the roots is far away, in particular the apex, is far away from its normal position. And so it creates most complex condition to recover the position of the canine. So this is some of the preventive factors that we can respect to avoid this problem in kids in particular. But once that we recognize this problem, it means, of course, that we need to, first of all, localize the problem. Nowadays, this is a really easy procedure because with all the CBCT comes to be really common and easy to understand where is the precise position of the canine. Then we need to create the proper space, for example, and then we can move to a precise surgical exposure, then bonding, and then we start the anchorage and we start the traction of the impacted canine. Talking about localization, a really easy way to understand the prognosis of the canine has been suggested by another two fundamental researchers like Professor Erickson and Kurl, that introduced a really nice system of assessment on the panoramic X-rays. So if we set the midline between the central incisor and we analyze the angle that is created by this line and the angulation of the canine, which is called A, we can first assess the difficulty of the treatment and somehow the time of the treatment. Then we can divide some other vertical lines assessing the long axis of central, long axis of lateral, and interproximal line. We have different sectors, as we call S1, S2, S3, S4. The position of the canine in this different sector can affect, of course, the severity of the impaction. And finally, one other interesting factor suggested by these authors, I think that this is something amazing because it's really easy to understand before the CBCT, is just a immediate analysis, is the distance between the tip of the cusp of the canine to the occlusal plane. So this is something that we can easily do. I think this is a really smart way of analyzing the impacted canine position. And from here, some other Italian researchers introduced a really interesting assessment. So when you have an increase of 5 degrees of A, it means one more week of traction. 1 millimeter increase in D, which is the distance to the occlusal plane, means one more week of traction. And if we have the impaction in S1, which is the first sector close to the central incisor, means 6 weeks more when compared to S3, which is the position close to the deciduous canine, between deciduous canine and lateral. So this is a really interesting assessment, and it's really easy on the panoramic. Then we can assess the rest on the CBCT. After this, we start creating the space. Sometimes it is so easy because we can do with a liner, for example, creating spaces and opening the space between premolars and lateral. And when the canine is in position, the eruption will be automatic. Instead, in some other different condition, we need, after creating the space, planning our surgical approach. And the surgical approach should be based on what we can define the infracrestal eruption. Why I'm telling you this? Because this is, I know, is a little bit more complex, is a blind procedure because we open the flap, we bond the buttons, and then we close everything. And we start the traction on the tats. So the advantages, of course, are represented by a more natural physiological eruption, forced eruption. But the disadvantages are represented instead of the in case of debonding of this button, we need to reopen the flap as well and rebond the buttons. But this is a really uncommon condition for me nowadays. And for this reason, to ensure the patient the best periodontal condition, I prefer to do this kind of approach. So always infracrestal natural eruption. We have different papers talking about open eruption and closed eruption. And normally when we use an open flap and simply leave the open, and if we did some bone removal, of course, we cannot leave the bone in contact with the mouth open. So we need some healing pack, and this is something which is not hygienic, so hygienic. And this is the first problem. Second, we need, of course, to create traction, an orthodontic traction that could be open, so probably easier. But from the hygienic point of view, of course, all these holes will generate cavity in which is a little bit more complex for the patients to keep a really nice hygiene. And that's the reason why instead with the closed flap, we have an ideal healing and no problems in terms of hygiene maintenance because it's easier. So this is also the reason why, as suggested from some orders, I prefer. Moreover, it's easier sometimes to it's possible sometimes to do open flap when we have buccal canine. When they are palatal is a little bit more complex, and this is something that is really, really common in also in the periodontal approach in some periodontal journal. Finally, we need to find our best solution to bond. Some years ago, I was in the habit of using buttons and creating a metallic chain handmade. So I will do by myself using a metallic ligature, the metallic chain that you see in this picture. Nowadays, I prefer doing the same metallic chain, which is created, handmade by me, but combining this metallic chain with a mesh, a metallic mesh. The metallic mesh is something amazing because it's really a mesh which represents the part of the brackets which is in contact with the enamel, which is highly useful to bond and to retain the composite. So that's the reason why it's really uncommon to see the bonding. And of course, when we place, actually, we should be as much as possible on the tip of the canine. And as you can see from this picture, with the button, this is not so easy to do because with the buttons, we cannot really arrive to the tip of the cusp of the canine. While when we are using the mesh is really more precise. The mesh is possible to model and to create exactly the shape of the cusp of the canine. So we can apply the force in a more favorable direction. And this is the reason why I strongly prefer to put always on cusps and in particular to do with this metallic mesh. And finally, of course, after all this consideration, we can start our traction. So in aligner treatment, these represent something that, for example, as you see in this picture, one Dr. Kushal, who published this in the Journal of Aligner Orthodontics, is managing simply by using elastic chain directly connected with buttons bonded on premolars or asking patients to wear a intermaxillary elastics connected to the aligners, or simply using something that I think we all use, like the what we can call leading elastics. Of course, all this kind of approach requires an open flap procedure, okay, because it's not possible to apply this kind of forces when we have a natural closed flap eruption of the canine. And for this reason, they are not always possible, first of all. And second, in my opinion, sometimes this kind of approach could not represent the ideal anchorage. So when we have not so complex canine, impacted canine, we can try this one. When we have more complex impaction, it will be a little bit more difficult to achieve. So I don't know if this is an ideal condition of anchorage because we really need, in particular, by using this kind of elastics, we can, in case the patient is reducing the time in which is wearing aligners, we can be in trouble because in the next, after a few hours, more than 2 hours, that the patient is not wearing the aligners, we can see a change in the position of the premolars, so we can lose anchorage. So that's the reason why this could be interesting when the impacted canine is not so big. But when we have a really severe impacted condition, I don't think this is the ideal anchorage. And in particular, using elastics, intramaxillary elastics that the patients should wear, it means that we need to trust in the cooperation and rely in the cooperation of the patient. This is the reason why I prefer actually to approach this one with my TADs. And that's the reason why I combine these two things together. And I think this is the ideal condition to do that. And we can set two different conditions. One condition in which I can reopen the space with aligners and then doing my de-impaction of canine on TADs. Or situation in which we can immediately start with TADs for the impaction, so starting the traction of the canine, and then we do a consequent following phase of aligner optimization. So the steps are the same, let's say. We start creating the space, then we plan our surgical procedure. Even I'm talking about the step-by-step procedure combining aligners and tats. Then we decide on the base of the canine, impacted canine position, we decide what to do. We can have a V impaction that could be in an horizontal vector or a pure vertical force vector. Then we can use TAD in order to produce the biomechanics that we want and generating a direct anchorage or an indirect anchorage, following what is ideal for us. After the refining and recover the position of canine, we can refine the torque of the canine simply with a further phase of aligners. So we have a initial phase of aligners to create the space when we don't have the space, and a final stage again with aligners to refine torque position of canine. In the middle, we have a lot of traction, which is based on the connection between TADs that could be sometimes direct, sometimes not. Let's see some example just to be a little bit more precise about this. And let me show you a young guy, teenager, 17 years old, that came to my office with this kind of situation with midline deviation, central incisor diastema in a normal profile condition. When we see the occlusion, we are in a perfect class 1, really ideal class 1 on both sides, left and right. We have light crowding in the lower, spacing in the upper because we have the persistence of the upper right deciduous canine. We have a moderate V bite, and when we ask for our panoramic, we have this situation. So it's not a complex condition, as we can notice from this picture. So if we analyze doing all the settings or about the A angle, D angle, and sector, the canine is pretty easy. When we look at the CBCT, this canine is a little bit more lingually, palatally inclined. So it's not perfectly in its position in the bone, but it's not exactly in the bone crest in the middle, but it's a little bit more displaced palatally. Not so much, but a little. So in my problem list, I should simply keep the occlusion, which is perfect. And sometimes it's not easy when we have an impacted canine to keep the occlusion, so it's not something normal. We don't have any vertical problems in this guy, so moderate the bite, but we have an impacted 1.3 with this kind of midline deviation because, of course, spaces are open because of the absence of the permanent upper right canine. So my objective is to recover the position of the canine. But first of all, I need space. And so I can find space by expansion. I can use the Bolton discrepancy button that I have available on my clean check so that I know that the 2.3, the upper left canine, has a dimension, and I simply try to respect the same dimension on the opposite side. So I will open the space sufficient for the impaction of the right canine. I need to redistribute the spaces, so space redistribution by means of centering the midline, so all the teeth are moving to the left. And in particular, what I want to create, since the canine is a little bit palatally displacement, few millimeters, I can probably use an anchorage at the beginning. And in my treatment plan, in my clean check, I have 23 aligners in which what I'm doing is simply don't change the posterior occlusion, except some torque in the anterior, opening space mesial and distal to the deciduous canine. As you can see, the deciduous canine is locked in this position, so is unmovable. And I simply use the deciduous canine to open the space. Simply alignment and leveling in the lower arch, so nothing special. But since we have a moderate uh, T-bite, I'm using together with that bite trams to open the bite a little bit more. Okay, so 23 aligners, I can change at the beginning every 10, and then I can reduce at 7. And then I can arrive to the moment in which spaces in the front are closed, occlusion is kept, but I have the need of displace buccally the canine that was on more palatally displaced. So I can combine a TATS. This is a TATS of 8 millimeters with a diameter of 1.3 is what we can find in Italy called HDC. This is the name of the company. And the screw is a spider pin. Spider pin, a really thin screw, 1.3 millimeters diameter, 8 millimeter long, just to create connection. What you see is the system of a metallic mesh connected to a coil spring exerting exactly 150 grams of force. Patient is wearing the aligner with some specific cut in order to keep the position. When we arrive in this stage, I don't need any further buckle force, but I need a vertical force. So no more horizontal, more vertical force application. So in that case, what I decided to change is using a sectional, which is a 16 by 22 wire with a vertical force for extrusion of this one impacted 1.3. As you can see now, I see more crown on this canine. We can go on in my treatment. And if needed, I can combine really often a cantilever, which is working even more efficiently than the previous system. And I can do 17 by 25 TMA wire in order to apply a cantilever force. This is based with a tube bonded on the second premolars and a loop creating extrusive force on this canine. I can combine this with aligners, but I can do even better because nowadays I do something different. Instead of reactivating the cantilever, I asked for some additional aligners. And what I did from this point is creating a cutout on the lingual side. As you can see, there are some lingual extrusive force on this canine with lingual cutout. So what I'm doing is trying to combine uh, a vertical force exerted by the aligners with a vertical force exerted by a lingual sectional that I'm trying to bond from the lingual side. This is a night-eye wire, which is bonded on 5, is bonded on 4, and is not bonded on canine. So as you can see, there is only a composite stop for the extrusion of this canine. As soon as I see that the system is working in the extrusion, I simply change the position of the composite stop in order to reactivate this kind of cantilever made of night tie or copper night tie, whatever you have available. So in this way, I can go on with the treatment, and at a certain point, I will not change any more aligners, so I can pause my aligner treatment using always the same retention S6, and in the meanwhile going and extruding the canine. This is the situation at this moment. Is not still perfect, so I can spend some extra time, only 7 aligners changing every 7 days or 5 days to create more extrusion and more rotation of this canine. And simply with this approach, as you can see, I'm not moving anything else, only the upper right canine. And with this approach, with a beveled horizontal attachment, beveled gingival, I can achieve my final result with a nice +1 occlusion, full correction of the canine. And what I really, really like is that when we normally do the kind of closed eruption, the gingival, the periodontal tissues, and the soft tissue look healthy and more natural than when we do an open flap eruption. So it's more physiological approach. This is the full eruption of this canine and the end of my treatment. So of course, generally, when we analyze impacted canine, the system is not so rapid, is not so efficient, and this is pretty normal because, of course, the biology of the impacted canine is a little bit more complex. And so that's the reason why we can spend 1 year, 1 year and a half in this. And this guy was 1 year and a half at least in order to recover the full position of this canine. But the idea to combine, in that case, stats and a sectional was, of course, the idea of avoiding any collateral effects on the vertical position of one occlusion that started perfectly, and so was simply the idea to keep in the same. And something that I normally do in all of my treatments is trying to compare real condition to digital plan. And when I find let's say a superimposition which is pretty close to 100%, I'm really, really glad because it means that my treatment plan was proper. And in particular, it means that the cooperation of my patients was pretty high. Okay, in that case, was also the biomechanical system for the impaction efficient. Easy case. And when we start looking at the face of this guy now, which is the smile, of course, is more balanced into the face. When we compare rear, the beginning and the final, these are the differences in the smiling in the frontal view of this guy. But what is more interesting for me is that we have a nice parallelism and in particular unhealthy bone in this canine that has been extruded, forcibly extruded. But as we said, easy condition. We are not always so lucky. So sometimes we have more complex situation to manage in terms of impacted canines. And let's see step by step something which is going up, so which is a little bit more complex. And let me show you another interesting case of impacted canine. It's always following the same approach. But in this case, we have a full deep bite condition. Again, some spacing and diastemas in the upper arch as well as in the lower arch. So we don't have any particular problems related to space in this girl, on lack of space, because we have an excessive space in the upper because of the persistence of the upper left deciduous canine. We have also a not ideal occlusion because of the vertical deep bite and the position of the first premolar, which is biting in a shiso bite, which is too expanded for the lower. Spacing and rotation in the lower, and this is the situation on the lateral ixus with a hypodivergent pattern, and in particular, this is a little slightly more severe impacted condition of this canine. So we have a class 1 dental and skeletal, but the pattern in this case is a more severe hypodivergent pattern. We have the bite and spacing around in the upper arch as well as in the lower. When we look at our values, this is the angle, the distance from the occlusal plane, and in particular the sector. So again, it's a little bit more complex, but not so dramatically complex impacted canine. So I just selected something that was in the middle, and then we will finish with one of the, of course, more complex condition. So this is not so complex, but in my treatment plan, again, first of all, I need to fix the malocclusion. I need to redistribute the spacing in the upper arch, proclining the incisor. In that case, again, using bitrans because we have the bite and redistributing the space. We have, again, the Bolton, which is telling us the dimension of one canine in the upper. So what is calling 2.3 is instead the 6.3. So we are talking about the deciduous. So we know precisely the difference between one and the other. And this will be helpful because we can open the space on the clean check in order to generate a proper space for canine de-impaction. And of course, this is something that I always do, in particular when we have only one side affected by the impaction. But normally what I try to do is open in with a more space. So I leave more space to my movement, which is not exactly calibrated on the opposite canine space. I leave in advance. I leave more extra millimeter in order to be precise about my treatment and avoid to be obliged to reopen the space. 29 aligners, teenager patients, 14 years old, and this is what happened. So retraction, space distribution, this is a deep bite condition, so I need intrusion in the upper, leveling in the lower, and I'm combining the bite ramps in this situation that you can see on lateral incisor. So they're really helpful, and central incisor. Correction of the transverse problem related to the shiso bite. And then we see the leveling of the cavus B that was not so much deep, but we need to close all the gaps, retracting the incisor, and at the same time giving the proper reverse curve OSP. Nice occlusion in my clean check. Respect again of the differences in terms of dimension of the teeth. And then I can, first of all, create the space. So this is the initial condition, and this is after 20 aligners. So we see the space opening, correction again of the deep bite, closing all the space in the upper, but as you can see, keeping a proper intercuspation in the back, in the posterior teeth. Fantastic. So from now on, as you understand, I simply remove the deciduous canine when I'm approaching the surgical open eruption technique, closed eruption technique. So the surgical part of the impacted canine. And when I do this on the same day that we create the flap with my surgeon close to me in my office, I use the same anesthetic just to put a couple of screws in this case. They are a couple of same screw HDC spider pin, but these one are longer, 1.3 millimeters diameter per 10. So same diameter, longer screw because I put in the back, as you can see here. So one of them is in one of the best position ever, which is mesially to the first molar on the palatal side. This is a specific safe zone here because the quality of the bone is amazingly good in that area. So when we place a TAD over there and we try to remove, it's really complex actually. Then, as you can see, I can apply my cantilever system based on possibly a TMA 17 by 25, and then I can start extruding the teeth. This is exactly a direct anchorage because we don't have any teeth involved in the anchorage, but is a direct connection from the screws directly to the impacted canine. And when possible, this is my choice. So this is my preferences because, of course, when I can do this, it means that I'm not involving any other teeth inside my anchorage unit, but I only use a couple of TAD. This is the ideal condition, but of course, it doesn't mean that I will extrude the canine always in this position because sometimes we can change. So this is a direct anchorage, but and this is the way in which I'm using the aligners. As you can see, these are the Invisalign aligners that the patient is wearing. They are passive from now on, and I'm simply covering the buccal surface with a varnish with the same color of the teeth. That in this way I will avoid that patients can go around with a hole and with a missing tooth. So this is something amazing because it's increasing also the compliance from our patient. On this particular stage, I simply wait for the eruption of canine. When I see the cusp, and I see that is a little bit more rotated, so I can combine something really interesting. And what I'm doing just to simplify my mechanics, I can change from a direct anchorage, also because as you can see, I missed one of the TAD, and so I change it in indirect anchorage. Indirect anchorage is based on a stainless steel wire connecting the first premolar to my TAD, to the mini screws, and on the buccal side, 18 by 18 night eye sectional, which is directly bonded on the buccal surface of premolars and is acting like a buccal cantilever. So in that case, we use the elastic force of the night eye just to push buccally the canine. So, but in with the sectional, which is a rigid connection with the tats on the lingual, we avoid any kind of reactional forces on the first premolar. This is what I planned, and after a few months, we see immediately this kind of effect of pushing buccal the canine. Always with the same wire, with the same piece of night eye wire. So I change it from direct to indirect anchorage. And from now on, I can change again. So I can leave, now I see the canine, so I can leave the system working in this way. Of course, the patient was wearing aligners just to retain all the rest of the position of the teeth and but cut in a proper position just to allow the sectional to push canine in a more buccal position. After this one, what I can do is simply keeping my lingual sectional, and I can combine a couple of buttons because canine is still distal rotated. So I can simplify my derotation. And in this way, I'm just playing with my sectional. And this will reduce the need of and the number of aligners, in my opinion. So I can arrive up to this condition. So still I'm in a class one, and now I can simply do a new scan the patient again, and try with the again with my aligner system to refine the position of this canine. Of course, in that specific condition, as you can see, we are approaching the end of the treatment. I can this is the clean check number two with a huge number of aligners, actually. But of course, the amount of movement is so small, so that I definitely decided to change every 5 days for this particular patient because I'm not moving so much. Have a look to the superimposition system. I'm not creating a lot of movement. I'm moving only on the left side of the arch, actually. So that's the reason why I decided to change every 5 days. And with the button and elastics, and then as you can see, I can use as well as my friend David Couchat leading elastics in the paper that I was showing to you. And these leading elastics are really useful because, of course, they are forcing the extrusion of the canine. They are passing through the aligners and connecting on the lingual side to the tats. To do this kind of approach with leading elastics, I normally use, because the screw was really far from the occlusal plane, and so I was obliged to use elastics 1 for exerting 6 ounces. And I normally do this kind of approach anytime, and leading elastics are a fundamental part of the treatment, but we only use for refine the position, not to erupt from the lingual, from the palatal, this approach. In this go, I'm now treating, still in progress, in 15 months. And in 15 months, this is the result that I achieved. Of course, once that we have TADS, we can do whatever. So it's simply to our fantasy what we can do. Because when we have TADS, I can combine and model by myself, for example, a TMA spring, a multi-loop TMA spring, sectional, which is bonded and locked on one TAD, and I simply push in order to create extrusion more predictably. So this is up to our fantasy what we can do once that we place a skeletal anchorage, stable skeletal anchorage in a good position to generate the extrusion. And of course, this is beginning of the malocclusion, V-bite, schizobite, ectopic canine, and this is the moment that in which I arrive at now. So still in treatment, but as you can understand now, the extrusion will be absolutely easy. But looking at the uh, gingival condition and the periodontal soft tissue, we don't see any differences between the right canine and the left canine that was impacted. This is the big advantages in working with this kind of closed eruption approach. And again, we see the difference between what I planned and what I achieved. And as you can see, in all the rest, still canine is extruding, but as you can see, all the rest is exactly respecting my digital plan. I still keep the tab. I will remove when I full finish the my treatment, but until the end, I still keep in case it will be helpful for me to use it in some specific condition. And this is the smile of the girl and the aging, let's say, the growth of this nice girl from when she was a little bit younger until now, when we still are pretty finishing orthodontic treatment. But this was, as we said, a little bit higher and all condition in which we needed to create the space before and then finishing the position of the canine with a further aligner stage. Sometimes we can start immediately with a de-impaction on tats, and only later we can move to an aligner stage to refine canine position. But the steps are always the same because, first of all, we create the space. Second, we start with our ideal surgical procedure, selecting the proper bonding material and the proper bonding tool. Then we start with our vector of force of traction, horizontal or vertical, depending on the position of the canine. And then we can start selecting the ideal position for tats and base it on a direct or indirect anchorage on tat. And this is fundamental also because sometimes in a really complex condition, we can combine tats with some other surgical procedure that can be helpful in what we are doing. So let me show you one further condition of adult patients. So I showed only teenager. Now I'll show you an adult patient of 44 years old with class 1 malocclusion on both sides, a really nice intracuspation, no vertical problems, some crowding in the anterior. Let's have a look at the rotation of the lateral incisor in the upper and lower arch. And again, persistence of the upper left deciduous canine, which is absolutely 100% mobile. And she is really, really scared about losing this deciduous canine. This patient went to at least 10 orthodontic office before me, and all of my colleague orthodontists proposed to extract this canine and place an implant. Of course, she was not so, let's say, agree with this kind of treatment, but I was the only one suggesting to recover the position of this canine. And I said, I think that this is the only option because if we do an extraction of this canine, this will bring a lot of bone removal. And if you have bone removal before doing before placing an implant, it will be really, really difficult for us to find the proper bone volume. So that's the reason why with all this problem, light crowding, a deep impaction in this case, and the mobility of 6.3, I set my ideal treatment, first of all, in creating a proper direction of the orthodontic force. So let me share with you my treatment plan. I decided to de-impact the canine from the beginning directly on one single tab. And my first direction was distal because look at the position of this canine. This canine is impacted. The crown is on the palatal side. The root is in the buccal, but the crown is really, really close to the lateral incisor. And this is really dangerous because when we normally start with this is the shape of the canine, and when we start with a direction which is absolutely buccally, the risk is that the tip of the cusp of the canine can touch the roots of the lateral incisor, creating resorption. So, first of all, our force direction should be distal and then can be buccal later. So, and finally, after doing my uh, de-impaction, I can move to aligners later. That was my treatment plan. And of course, I always plan this one uh, uh, with my surgeon. So it means that I have an orthodontic office only. But normally, when I need uh, to do and treat impacted canine, I ask the surgeon, the oral surgeon, to come into my office and we spend a day together just uh, treating and planning our surgical recovery of the impacted canine. And for this girl, we decided to do this. First of all, laser gingivectomy because the canine was only from the palatal side with a mucosal and gingival inclusion, but was not covered by bone first. So we can approach with a laser gingivectomy easily without blood, so without bleeding. So that was the ideal condition. Second, always same single anesthetic, and I place personally my TAD, my anchorage, where in our safe zone, the safe zone described in literature, which is that kind of triangle of high quality bone, which is mesial to the upper first molar. Then I can place my system, and in this case, my system is represented by bonding system, by mesh, by the small mesh that I was showing to you before, and connected and tied, as you can see in this picture, by means of a metallic ligature to a coil spring, a night-tie coil spring exerting precisely 150 grams of force. So it's a easy way to do it. So I can simply, I see that there is no bleeding. I see the animal and I can simply bond my mesh on this canine. So I cannot go properly on the cusp because of the really close position to the lateral incisor, but I can still be having a more wider surface of bonding instead of the button. So that's the reason why I prefer using the mesh. Mesh is not easy to find actually, but it's really, really so useful. After this one, now I can connect my system to the TAT. But before, since I'm treating a 44 years old lady, I decided to ask my surgeon to create some piezo scission cuts. So it's using the piezo surgery just to create some vertical cuts into the let's say, the path of eruption of this canine because I want to simplify and the movement of the canine, and I want to create more easier for this canine to erupt. So that's the reason why I asked for some cuts of piezo and only after I placed my system and I attach the coil spring to the TAD. Now I can forget about this one. I can simply send the patient exactly as she was before coming to my office in that day, no aligner, nothing, and I simply wait. And I wait for, of course, 1 week. This is the healing at 1 week. Since the deciduous canal was really mobile, we decided to fix with a retention wire just to avoid any problems. And in 1 month, I start seeing the buccal surface of the canal because this one is the buccal surface of this canal. Amazing. So 1 month, and I see this correction. Then we were facing the summer vacation, and so I saw my patient coming back from the summer vacation, and this was the result in 6 to 7 months. So canine was fully corrected. Look at how exhausted is the coil spring now. So fully corrected in a short time. And now, of course, I can change the force, my direction of force, because I don't need anymore this kind of direction. Is even too much activated, probably. But as I told you, there was the let's say the summer in the middle. So that's the reason why I was not able to see this patient because she simply left. So from now on, I can change direction of force. And how can I do this? On the same appointment, I remove the TAD from the lingual, mesial to the sixth, and I place on the buccal surface mesial to the first premolar. So I generate another buccal traction of this canine. Of course, I was obliged to extract the deciduous canine, and this created a lot of problems to the girl and a lot of problems to me, consequently, because of course uh, she told me I can't go around without with a missing tooth, so I need to have something covering this hole. And so I'm not a good restorative dentist, but at all, because I'm a pure orthodontist, but I tried to do something similar to one canine that was simply bonded on the mesial surface of the first premolar, including and bending the TAD. So in this way, I created something that was not beautiful, but at least stable. But at the end, I will give you my new invention for this problem because it's really so common. Okay, so I can continue my traction and I can move this canine buckle. When I see that the coil spring again is exhausted, instead of removing my fake canine, I can remove the button and place more mesial so that I can reactivate more easily the coil spring. And I can simply wait until I'm tractioning and I'm pulling the canine on a buccal surface. When I see that canine is really close, at this point, I can scan the patient and start my aligner treatment. And that's exactly what I did. So class 1 occlusion, so I don't want to change, but I want to keep. And what I'm doing is moving buccally the crown of the canine. So controlling the roots, but actually moving on a buccal direction. As you can see, since I'm moving in a buccal direction, what I'm doing is placing an horizontal attachment, which is beveled on the gingival, so that the force exerted will find a wider surface in order to create this buccal movement. All lingual attachments, which is my common uh, configuration of the attachments. I don't use on the buccal anymore, only on the lingual side, from 5 to 5 in the upper and from canine to canine in the lower. Nothing really special in the lower arch, simply developing of the shape of the lower arch and 38 aligners that we decided to change every 7 days and then squeezing at 5. No change in the posterior occlusion, just to keep exactly the same good posterior occlusion. And this is what happened step by step. Initial, some months in treatment. As you can see, I start immediately using a system called leading elastics just to control the position of the extrusion. In this case, since elastics are a little bit shorter and they are connecting the buccal button to the lingual button, passing over the aligner, so the patient should wear, I use 316 elastics exerting 6 ounces. We can go on with this system until we reach a more ideal position of the canine. Now we fixed the position. From a lingual inclination, we are in a more buccal position, so no more in crossbite. All the rest was pretty fixed in the lower arch in the right side. Now we still need more extrusion. So just to fix this problem, I did, this is a control X-rays for now, and I did an extra aligners treatment. As you can see, moving nothing but the canine and the lateral incisor. And I left the space with cutouts on the lingual side to apply the same extrusive system that I showed you before. And the same extrusive system is based on a sectional bonded on the lingual side in the spaces I left from my cutout. So as you can see, this is the angulation and change of tipping of this upper canine, and I will bond my system exactly on 5, 4, and 3. But I will bond on 5 and 4, and I will simply create a stop on 3. So my sectional wire is not fully exerting force by bonding on the canine because I simply need a cantilever. So to have the cantilever, as you can see, the system is bonded here on 5 and 4, but is not bonded on canine. It's just touching the composite buttons on canine. In this way, this is a night tie wire, or if you prefer, copper night tie wire. Of course, the aligner is guiding the movement so that we can achieve a successful extrusion in a reasonable treatment time. And this is exactly what happened to this girl at the end of the treatment. So class 1 occlusion on both sides with an interesting extrusion that comes from this system, all the system that I showed you. So I tried to fix everything as much as possible with TAD, and then finally I arrived to use aligners. Pre-treatment on the vertical, sagittal, and transverse dimension, and post-treatment showing exactly the success, the good reaction to periodontal tissues to this treatment, and of course, the transverse correction of the malocclusion. So this is a really nice option, in my opinion, because in this way, we can move canine and we can respect our treatment, the aesthetic of the patient. So look at the smile at the end. Nice profile, the same that we have at the beginning, but for sure a more balanced anterior smile. Long treatment for sure, because I spent 25 months, so it's not easy. But don't forget that the patient was 44. So, of course, it's easier when we are treating teenagers, is a little bit more complex when we are treating adults, in particular, not young adults, but adult patients. So this was something a little bit more complex for me. And as I told you, one thing that was affecting my mechanics was the hole coming from the missing canine. This is the reason why I created, together with my lab, a shell that I called customized G shell. And this shell is something that is based on a laser melting procedure. Okay, so my lab create this shell with a laser melting process. It's really thin, and over this shell is using a special colored resin and composite that is perfectly covering the metal. So generally, I can bond with a glass ionomer cement on the only on the buccal surface of the first premolar, as you can see in this picture. And I have this shell here, which is covering the hole, and I have the possibility to work with my tabs here on another tabs here, whatever you prefer, just to refine the position of the canine. So this is something really helpful in my opinion, in particular when we are treating uh, young adults or adult patients and they don't absolutely want to go properly around with a missing tooth, so with this hole. And in particular, the varnish that we are putting inside the aligners are a solution, but don't forget that when people it's going around for dinner, for example, they don't have the habit of eating with the aligners. So this could be a nice solution because once that we place the G shell, we can scan again and we can have an aligners which is including the shell. So in this way, we can work more in a more relaxing way and the patients will be more comfortable since there will be a sort of fixed coverage of the hole. And this is something that I really found amazing. I think that giving the proper indication to your lab, it will be absolutely easy. Nowadays, with the customized bands or customized laser melting procedure, it's really, really easy to have this kind of shell available for what we are doing. And this is actually what I prefer nowadays to do in mostly all patients. But there is another option if you are, because I showed you a possible connection with that. But in my opinion, thanks to the digital technology that we are using nowadays, we can also give space to our fantasy. And our fantasy could, for example, in this way, as you can see, this is a impacted canine condition, bilateral, that I'm still treating in this moment with a system that I personally, as you can see, designed. And I designed it with my Apple Pen on my iPad because this is a picture of the scan. And I simply decided and sent this one to my lab and said, I want to create an anchorage. I want some customized shell on the lingual side based on a laser melting process. And I want the possibility to combine a TMA, but with a different dimension, the one that normally we use in the lab, to create a cantilever for the canine extrusion. On the opposite side, as you probably can notice here, we have tabs that are locking the position of the first premolar, one on the right and one on the left. So I will use the reaction forces simply by using this omega loop, and I will use again the tabs together. And then I can apply extrusive force on canine. This way it could be easier because you don't need, you see the system into the mouth. So from my personal idea, simply by drawing, I send to the lab and the lab can create whatever we like. So nowadays it's pretty immediate just to create this kind of connection. And it's really amazing because of course we have stable anchorage point. We can combine tats to maintain stable the position of premolars, but in this case, since we need a more extrusive force, we can use TMA spring modeled by the lab for example. So this is something that the lab can do easily, and it does not require any special modeling by yourself. So this is up to you. This is something, this is my one of the option that I'm doing nowadays, because I showed you the use of TADS, and sometimes we can combine TADS with digital lab design. This could be another option that I sometimes uh, try to create in order to fix all my problems. But nowadays, the new approach that I'm following is a little bit more efficient, in my opinion, because what I'm trying to do nowadays is always using a couple of tabs. So you see a case in which I opened the space with aligners, and now I'm using not one, but couple of tabs to create this kind of cantilever. I think that I changed the position, so I'm using one tab missile to the 6 and the other one on the same line, as you can see here, exactly on the same line, but between one first premolar and second premolar. This is the activation that is extruding the canine. So it's always with the same open, closed eruption approach. This cantilever is based on in this case, on a TMA 17 by 25, which is actually, in my opinion, the most useful condition to do this. And I decided that I want always nowadays, from nowadays on, to de-impact canine with aligners with at least a couple of tats, okay? Because at least with a couple of tats, we can be more efficient. Is that terms of efficiency? Because of course the aligner treatment will be more fluent and more smooth, and it's easier. We can start with one TAD, then we can combine the other, and then when we combine the other, we can simply model a 17 by 25 wire. So as you imagine, I love to do this one because it's something which is not so complex if you are in the habit of modeling, and it's more and more reliable. It's really easy. As you can see, there are no specific, the sectional made of TMA is just, let's say, not fully blocked into the TADS, into the TADS head, but it's just positioned. And then, as you can see, I use some composite just to fix the position. Let me show you a little bit better in this video what I'm doing. So this is a condition in which I see the canine now. So canine is, let's say, erupted. And I want to change the position because I need to move more backly. But I have a couple of tats on the lingual, the one that I used for eruption of this canine. So what I can do is modeling this kind of, let's call power arm, okay? And you see that I model it by hand, creating a hook and creating a omega simply here and a hook here. So we have one direction here and one vertical loop here and one horizontal loop. So in that case, when I place on the tats, of course, I need to pay attention. Sorry for the quality, which is not ideal. But I need to pay attention because, of course, paths are not perfectly parallel one with the other. But this is not a problem because I can model my wire in order to respect this two inclination, which is not perfectly parallel. Because, of course, I put exactly where I found the bond. So that's the reason why they cannot be precisely parallel like an implant. And also because we have the roots of premolars and molars. So that's the reason why we need to change the modeling the position of the wire. After this one, and as you can see, there is no movement, I place the bonding material without fixing this sectional in a more proper way. This sectional is a stainless steel 16 by 22 wire because in this moment I don't need an elastic force, but I need a more rigid force in order to move the canine more backly. So as you can see, I'm using my common composite, which is more than resistant, in order to fix the position of the my sectional on the mini screws, on the tabs. After doing this one, of course, I'm light curing this position. It's something that is not properly on time, on real time, of course, but is not what is really time consuming is modeling the power arm. But once that if you have the habit of using and bending wire is not so complex. After this one, as you can see, I still just spread the composite over the tabs in this moment. And once that I created my fixed rigid sectional wire, because as we said, this is a stainless steel wire. After this one, I can create a direct connection with the dots. So this is a direct anchorage, which is absolutely useful in order to move the canine. So I can use an elastic chain easily that I can place in this position, and then I can simply cut. Of course, to avoid any kind of noising and problems to the mucosa, to the internal cheek, I again use composite just to avoid any problems. This is the deflection of the wire, and still it means that I'm moving canine more backly. And this I'm doing this because I want to avoid any involvement of the teeth, exactly as we said before. So still trying to keep as much as possible a direct anchorage between the tats and the impacted canine. So this is a common solution for me. The final step nowadays is then, as you can see, cutting the aligners. I think that all of us working with the aligner system, we have a lot of pliers creating cuts. The one creating cutouts, the one creating precision hooks. So we have all this kind of pliers that are really, really useful. And however, sometimes I use a blade simply to be more precise in the cut and to avoid that the system is touching the aligners, but still keeping stable all the other teeth. Okay, so that's the goal of this system. So nowadays, any kind of impacted canine, I approach in this way. I first start with one screws, and then when I need a more vertical forces, or in case I need a more buccal forces, I change from one TAD to two TADs. I model my sectional, I bond the sectional on the screws, and I simply connect an elastic forces from the system directly to the canine. So I try to avoid as much as possible the indirect anchorage because I prefer the direct one. This is one option. It's something that is working. All the reactional forces will be absorbed by the mini screws system instead of going to affect the teeth position that can be maintained stable by the aligner system. Okay, so this is actually what I'm doing today. So let me move to conclusion because we are quite at the end of the time that we have available for this webinar. And let me tell you that, of course, this is all my skeletal anchorage experience that actually started with a palatal implant that was osseointegrated when I started in 2002 together with my group of Professor Giancotti, we were the first to use an osseointegrated palatal implant to create a stable anchorage unit. Then we combine it with Fixit, we combine it with aligner system, and then we dedicated time to the mini screws, to the TAT. And actually, this is something that, together with some Italian friends, led us to write a clinical book together. So this is a text that you can find also in English language. That it's something that we wrote some years ago, but we are, let's say, writing a new one, a new edition with all a chapter including the connection between aligner system and TADs and orthodontic mini screws. But the idea is, in my opinion, in the philosophy is this one. We have the screws and we can do whatever we want. To be honest, I don't know. I don't think that mini screws or TAD are like a sort of magic wand. So whatever we want, we can achieve. I think that everything, as Dr. Peck published in the Angle of Orthodontist of November 2018, we don't have a with orthodontics. With orthodontics means, because it's a strange word, it means that we can use whatever. So it's not the goal and the outcome of the perfect outcome that we are looking for is not based on the appliance, but is based on what we are thinking. Is based on our diagnosis. It's based on our ideal treatment plan, and of course, is based on the skill that we have in creating the proper biomechanical system to achieve the success of our treatment. But even a beautiful system like the TAD and the mini screws are not the solution to all our problems. So that's the reason why with orthodontics, so we can do and we can achieve success with any kind of system, with any kind of orthodontic appliance. But what is fundamental is that the tools that we are using should follow necessarily a precise diagnosis and a precise treatment plan. And then, only then, we can select our tools, our instruments. But first of all, we need an ideal biomechanical plan. And this is the reason why then we can use with success TATs. So don't think that TATs will be the solution to any problems. And in particular, when facing the aligner system, we need always to combine these two things together. So what does it mean? That it will never work if we don't plan for a logical digital setup. Logical means that we need to consider where is the center of application of the force, the center of rotation, and where is the center of resistance of the tooth. And if we respect this one and we apply our movement close to the center of resistance of the teeth, we can be successful. If not, we can create a digital setup which is not logical, which can work really nice on the screen, but will not be possible and reliable on the real life and on the clinical aspect. So that's the reason why we need logical and digital, a logical digital setup. In my idea, but this I recognize this is absolutely my personal opinion. If you want to be successful in our aligner treatment, we need a sort of personal setup. That's the reason why I always take care personally of all my clean checks. So this is not why I don't trust in technician, but this is why I have the patient here. I studied orthodontics, I studied biomechanics. I know the biological limit of the patients. So the only way in my personal opinion, to be successful is moving teeth by yourself, is creating your personal setup, and only write to the technician to change, for example, the staging, which is something that we cannot do by ourselves. But actually, the use and the applying of the personal setup will lead to a more easy success. And of course, when we see a beautiful clean check, we always need to ask ourselves, what do we need? We need to modulate the anchorage. For example, it means that we can combine some extra procedure like piezo like corticotomy, in order to uh, create a smooth and ideal workflow, an ideal setup. So we can combine these two things together, for example, and we can modulate the anchorage. Of course, anchorage is not built inside the digital setup, is not inside the clean check. So it means that anchorage is up to us. And so that's the reason why we can simplify the movements with some surgical procedures, or we can select our anchorage sources. And TEDs are an ideal anchorage sources because, of course, as I said at the beginning of this lecture, we can change the uh, paradigm of the science, because normally if we know that when we apply a force, an action, we will have an equal and opposite reaction, same forces but equal and opposite in an opposite direction. The only way to manage this is using intermaxillary elastics, or that will more or less control these reaction forces, generating some other forces in the opposite arch, or we can absolutely counteract the reactional forces by using TADs, which are stable into the bone and will be, they are and represent a real scientific revolution because they change something that is a dogma that we know about, the third law of biomechanics. And so we can select the anchorage sources. Looking for what? Looking always from an ideal intracuspation, a proper occlusion, a normal guidance of anterior movement of the mandible, and normal guidance during the lateral movements of the mandible. So we always need to check for a proper occlusion. This is something that I always do, not only in impacted canine treatment, but this is something which is normal for me. So this is a checklist that I always try to respect any time that I'm treating patients with aligners. And as I told you, this is something that I do 100% of my practice. And of course, finally, this balance that we are looking in the occlusal point of view should respect an aesthetic harmony of the face. This is the reason why I always showed you in my clinical picture the face of the patients at the beginning and at the end. And always, as you can see, I try to respect the midlines because they are really sensitive to midlines when they have a missing uh, permanent canine, and they have a lot of spacing very often, as you notice in this lecture. And above all, I need to respect the incisor vertical position because the smile arc and the smile line are affecting at the same time the balance and the exposure of the incisor. So that's the reason why we need absolutely to fix this in our orthodontic digital setup. So we need to fix on the digital and we need to fix on the real exactly in the same way. So closing this lecture, let me finish with one sentence that I really love it's really common for me to close my all my lecture with this sentence that has been stated and mentioned for the first time by an American engineer. So I'm not using words of an orthodontist, but of an engineer. And this engineer was Harrington Emerson, and he wrote a really interesting book that I suggest you to read if you like the idea. And this book was entitled The 12 Principle of Efficiency. You can find easily on the web, and is a book of the beginning of the century because this leading person in USA was lived at the beginning of the century. And talking about efficiency, and 12 principle of industrial efficiency, he finished one of the chapter with this beautiful sentence that is perfect matching for our aligner treatment. And the sentence is this one: the man who grasps principles can successfully select his own methods. So again, don't forget that we need to respect always the principle that we have learned in our past, in our orthodontic education. And in this way, simply respecting the biomechanical principle, simply respecting the biological principle, we can successfully select our methods. That could be tats, that could be aligners, that could be whatever you like. But the man who is trying methods, ignoring principles, is sure to have troubles. So this is one of the most true sentence ever. So if you try to use new methods like tats, like aligners, but if you ignore the principle behind the biomechanical principle, the principles, the biological principle, the special customized condition of the patient, we will for sure we will have troubles. And troubles does mean that we will create a problem to the patients, but trouble means that we cannot finish properly our treatment. Because if we think that tats are like a magic wand and they can fix everything, we can be wrong. And this means that we cannot finish in a efficient treatment time our orthodontic approach. So please try to, if you want to be more, to get more information about the principles, and then start selecting your own methods, and that will be successful. I thank you so much for your time today and for your participation to this webinar. In case you want to have some more clinical tips, some extra information on the way in which I'm working, I strongly invite you to follow my Instagram page. So you can see the name of my Instagram page here, Bishu Orthodontics, and I will be glad to connect and simply trying to give some specific clinical tips in my aligner orthodontic approach and in my digital orthodontics with aligners. So thank you so much for your nice time today. Thank you. And a big hug from Italy, because the picture that you are looking here is in the not so far from Rome.